My name is Axel Merseburger. I'm a urologist, chairman of the Department of Urology here at the University of Lübeck. The focus of the department and my own focus is prostate cancer, advanced urologic disease, metastatic disease, clinical trials, and of course, as a urologist, surgery and minimal invasive treatment of urologic disease. So due to our large clinical trial program, we have definitely more than 300, 400 patients with advanced prostate cancer in our trial program, seeing in our patient and follow-up and also in primary treatment of localized disease. So the treatment of prostate cancer has changed a lot. I did my MD thesis 20 years ago in the US on prostate cancer and then switched to Tübingen, and ever since then was interested in the research and the treatment of patients with prostate cancer, especially advanced prostate cancer. So the main challenges is how do you best follow up, how do you best diagnose prostate cancer, and in the later advanced disease, what comes after hormonal therapy, what comes after chemotherapy, what is last line treatment, and there are a lot of developments right now currently in clinical trials and in practice. So metastatic castration-resistant prostate cancer is a common end stage of advanced prostate cancer. First, you have metastatic hormone-sensitive prostate cancer. You start with ADT, and initially the neuroendocrine differentiated tumors is not an issue. It accounts for less than 1% of the patient with localized disease. However, in advanced disease, this is up to 30%, 40% of the patients that either develop or that genetically have neuroendocrine differentiated tumors, where you need to identify them and need to treat them best. So one good detection is, of course, a pathologist. So here we use biopsy and we make staining of, for example, somatostatin or CgA S100A proteins to detect neuroendocrine differentiated cells. Also, there are biomarkers with the PSA, which is not reliable in detecting neuroendocrine differentiated tumors, but we have chromogranin A, as the CgA test is really a good test to diagnose prostate cancer in the neuroendocrine differentiated setting. Both in serum and in histopathology. We use a CgA in the serum, but also as a marker in staining and immunohistochemistry. Once it comes to a neuroendocrine differentiated tumor disease, the value of the classical tumor marker which we have, the PSA, is limited. In addition to PSA, we have CgA as one good test, which correlates with a prognosis, which correlates with a treatment response. So the higher the CgA, the chromogranin A, the worse the prognosis, the worse the disease. And this helps us to identify patients that might, for example, benefit of somatostatin analoga treatment, which is still within a testing phase, which is not approved yet, but there are some ideas on how to use novel substances in neuroendocrine differentiated prostate cancer. So for novel treatments of advanced prostate cancer like apalutamide, enzalutamide, abiraterone, and possibly also coming darolutamide, so a lot of substances which are under development and in research right now in clinical trials, I would see great value in further differentiating the prognosis of the patient with markers like CgA to predict the prognosis, but also to tailor, to individualize the treatment when you know you have a neuroendocrine differentiated tumor, and when you know out of those clinical trials, looking at CgA compared to imaging, compared to clinic and PSA and old reliable markers, what is the value? And we can find out more on novel markers, and we need novel markers, not only like liquid biopsy, but also traditional markers like CgA. Looking at the cost, the monthly cost of RB-ENSA apalutamide, which goes into 1,000 euros a month, an investment of 15 euros on the test on CgA is, I think, a good investment in order to see where we stand. Once it comes to a progression, this can be done again. So I would recommend to test for CgA levels in advanced disease, especially in metastatic disease, especially when you use novel treatment like abiraterone, enzalutamide, apalutamide in the future. So I think it's a good, reliable biomarker. Surely we need some more prospective data, some more retrospective analysis, but it's a good way to have a hint towards the prognosis of the patient.